Hello, this is Dr. Tony Clark with learninganesthesia.com, and today we're going to talk about pre-op cardiac testing. So essentially, this is going to be a situation where you have a patient that's scheduled for surgery with known or risk factors for coronary artery disease. So there's 5 questions that are important you need to ask. The first question is this an emergency surgery? If this is an emergent surgery, then you do risk stratification and proceed. And you manage and monitor appropriately during the case. If this is not an emergent case, is the patient having active acute coronary syndrome? If the patient is having active acute coronary syndrome, then you evaluate and treat accordingly. If this is not acute coronary syndrome, then what is the risk of a major acute cardiac event during the procedure? There are a few different ways that you can evaluate if the risk of having a major cardiac event during the procedure. The most common one is the RCRI, or the Revised Cardiac Risk Index. So the RCRI takes into account 3 things from the patient's history and 3 things from the day of surgery. The 3 things for the day of surgery are, number 1, is it high risk? Number 2, is the patient on insulin? And number 3, is the patient's creatinine greater than or equal to 2? The next 3 have to do with the patient's history. Does the patient have a history of a cerebral vascular accident? Does the patient have a history of ischemic heart disease? And number 6, does the patient have a history of congestive heart failure? If the patient meets none of these, then the risk of major cardiac event is 0.4%. If the patient meets 1, then the risk is 0.9%. If the patient meets 2 risk factors, the patient has a risk of about 4%. If the patient meets 3 or more risk factors, then it's about 6.6%. So if the patient's risk of major cardiac event is less than 1%, you can proceed without further testing. If the patient's risk is greater than 1% or equal to 1%, then you assess the patient's metabolic equivalence. Metabolic equivalence is essentially the physiological measure of the energy cost of physical activities, and it's expressed in kilocalories per kilogram per hour. But essentially, you're asking what the patient's exercise tolerance is. Less than 4 meds are things like light work around the house and activities of daily living, doing the dishes, vacuuming, sweeping, and activities of daily living. Greater than or equal to 4 meds are going to be things like climbing a flight of stairs, can you walk several blocks, heavy work around the house, and low intensity activities like golf, bowling, etc. Greater than or equal to 10 meds are going to be strenuous activities, such as swimming, tennis, football, basketball, skiing. So going back to our fourth question,
If the patient is able to perform greater than or equal to 4 METs,
meaning they can climb a flight of stairs, walk several blocks, heavy work around the house, golf, bowling, etc., then you can proceed to surgery without further testing.
if the patient is unable to perform greater than or equal to 4 METs, or their ability to perform metabolic equivalence is unknown due to their current condition,
Then you need to ask the next question. Will further testing impact my care or decision? Because if further testing is not going to impact your care or impact your decision, then you don't need to continue to do further testing. But if it will, then clearly you should do it. So if there are less than 4 METs or the metabolic equivalents are unknown, and further testing will impact your care or decision, then you go to a pharmacologic stress test. If the pharmacological stress test is normal, then you proceed to surgery. If it is abnormal, then you undergo coronary revascularization, and then proceed to surgery. If further tests are not going to impact your care or decision making, then you proceed to surgery and manage risks accordingly. I hope this is helpful for whether or not you need to order further cardiac tests for your patients prior to going to surgery.